anesthesiologist. Generally, when we are practicing as freelancers, we do not have help readily available. So that time it really becomes difficult for us to, and it is very important for us to at least oxygenate the patient. So that time it is better to have a first look prior to taking the patient so that we know whether it is difficult or not. At least half of the cases we can reduce by checking these predictors. Today, by the end of this lecture, I am going to start with some definitions, assessment of the airway, planning strategies, and various algorithms for the management of difficult airway. Coming to definitions, what is difficult airway? Difficult airway is a clinical situation in which a conventionally trained anesthesiologist experiences difficulty with mask ventilation, with tracheal intubation, or with both. Then coming to what is difficult mask ventilation. It is inability of a trained assistant anesthesiologist to maintain oxygen saturation more than 90% using 100% oxygen and positive pressure mask ventilation in a patient whose pre-ventilation oxygen saturation was more than 90%. Then coming to what is difficult intubation. Difficult intubation is a condition in which a trained anesthesiologist takes more than 3 attempts or requires longer than 10 minutes to intubate the patient, and there is a failure of optimal with the best attempt. Then coming to difficult intubation. There is a scoring system. First, grade 1 is intubated by direct laryngoscopy in first by the anesthetist in 2 attempts maximally. Intubation by direct laryngoscopy by anesthetist where more than 2 attempts are required or has to be done by a senior anesthesiologist. Grade 3 is intubated by method other than direct laryngoscopy, and grade 4 is failed intubation. Then what is difficult laryngoscopy? Difficult laryngoscopy is the inability to visualize any portion of the vocal cords after multiple attempts at the conventional laryngoscopy. Coming to a very important topic, that is assessment of the airway. Why to assess? It is essential because we can do optimal patient preparation prior to taking up the patient. Proper selection of the equipments and techniques can be done, and we can get additional help, participation of the personal experience in difficult airway management. Then coming to the assessment, first we will be doing visual inspection and examination of the airway. Then there are some single parameter tests, some multiple parameter tests or group indices, radiological assessment, and advanced assessments. So coming to visual inspection and examination, first we will see for face for any abnormality or like microstomia, macrostomia, etc. We will be looking for teeth and incisors. There should be we should see whether they have any artificial dentures or loose tooth, etc. We should see for the nasal patency, see for the palate, tongue. Many times there is macroglossia which can lead to difficult intubation, or patients with C8 tongue especially. They don't have mobility in the tongue which makes a difficult intubation. Mandible, its mobility has to be checked. Oral cavity overall has to be assessed. We have to also see for tonsils because it can lead to bleeding which can further make the situation difficult. And lastly, the neck movements. Coming to single parameter tests, the first is assessment of the TM joint junction, assessment of the mandibular space and floor. We will be seeing assessment for the adequacy of oropharynx for laryngoscopy and intubation. We will be seeing assessment of the cervical and atlanto-occipital joint and thyroid to floor mouth distance. Coming to assessment of the temporomandibular joint, the function, we start with mouth opening or the interincisor gap. It should be normally more than 3 fingers. The interincisor distance should be more than 5 cm or more than 3 fingers in adults. For more than 3 cm, there is easy intubation. Less than 3, there can be difficult laryngoscopy. Less than 2, there you will have difficulty in placement of LMA. This is how you can check, either put the fingers in the mouth or you can check by the scale. Then second, coming to the Cantor's test or the lower jaw protrusion test. Here the lower incisors can be protruded anterior to the upper incisors, that is grade 1. Grade 2 is it can be in level with the upper incisors, and grade 3 is lower incisors cannot be brought forward, which becomes difficult. Mostly these patients will not have an adequate mouth opening also. Then coming to upper lip bite test, it is you can grade 1 is you can bring the lower incisors and bite above the alveolar line. Class 2 is you can bring just up to the alveolar line, and class 3 is you cannot move the lower incisors forward. Coming to index finger dentition test, here we see for the joint mobility, put the middle finger of each hand inferior and posterior to the patient's earlobe, place the index finger just anterior to the tragus, instruct the patient to open the mouth widely. Here you will feel two distinct movements. First is the rotational movement that happens, and second is the advancement of the condylar head. If the presence of click or crepitus is present, it will suggest TM joint dysfunction. Then coming to the assessment of mandibular space and floor of the mouth. The first one is the thyromental distance. It will help us to see the laryngeal and pharyngeal axis alignment and tongue displacement. It is done by measuring the distance between the thyroid and thyroid cartilage to the mentum. And more than 6.5 cm is normal, where the laryngoscopy will be easy. 6 to 6.5 it will be, intubation may be difficult but possible. Less than 6 cm, laryngoscopy or intubation will be difficult. Then coming to hyometric distance, it is also a 3-finger test. Here the distance between the mentum and the hyoid bone is seen. Grade 1 is more than 6 cm, which will be normal or easy intubation. Grade 2 is 4 to 6 cm, associated with difficult laryngoscopy and intubation. Grade 3 less than 4 cm, where laryngoscopy and intubation becomes impossible. Then mandibular angle to mental symphysis distance. It will help us to measure the horizontal length of the mandible. It should be at least 6 cm. Coming to assessment of adequacy of the oropharynx. First is the Mallampati or extended Mallampati score. This is the most common test which we routinely see in our PACs. It is frequently performed. It describes the relation between mouth opening, tongue size and the pharyngeal space. Pharynx to tongue ratio, it gives the ratio of pharynx to tongue. More the tongue obstructs the view of the pharyngeal structures, more difficult will be the intubation. So the Mallampati extended classification is grade 1, where you can see all the fascial pillars, uvula, soft and hard palate. In grade 2, you cannot see the fascial pillars, uvula, soft palate and hard palate are visible. Grade 3, only the base of the uvula can be seen or may not be seen, soft and hard palate are visible. In grade 4, only the hard palate is visible. And grade 0, which is a modification given by Sampson and Young, when the epiglottis is visualized during the examination of the oropharynx. We usually think that it will be easy, but grade 0 also can be a difficult ventilation and intubation because the epiglottis is very large. Coming to assessment of cervical and atlanto-occipital joint function, it is, we give Magel sniffing position most commonly, so that the oropharyngeal, laryngeal and pharyngeal axis are aligned. Here the figure shows grade 1, where the patient is lying in neutral position. Here the oropharyngeal, pharyngeal and laryngeal are at a greater angle, axes. The B figure suggests a pillow under the head flexing the lower cervical spine, aligning the pharyngeal and laryngeal axis. And grade C is head has been extended over the cervical spine, aligning the oropharyngeal, pharyngeal and laryngeal axis and creating an optimum sniffing position. Most commonly the head ring that we use should be of 10 centimeters, or you can use a Poppet's pillow. Thyroid to floor of mouth distance. It indicates the position of larynx in the neck. It is normally 2 fingers. Then coming to sternomental distance, it is assessed by SAVA test. The distance between the mentum and the sternal notch is measured, and it is measured when the neck is fully extended and the mouth is closed. More than 12.5 is normal. If it is less than 12 centimeters, it is associated with difficult intubation. It is the single best predictor of difficult laryngoscopy and intubation. Then coming to modified sternomental distance, here we measure the distance between the sternal notch and tip of the chin in both neutral and maximum extended position. The increase in the distance with extension more than 5 centimeters is easy laryngoscopy, less than 5 centimeters is difficult laryngoscopy. Then coming to quality of the glottic view during laryngoscopy. Here we can do various, this can be done in various tests, various methods. First is indirect laryngoscopy, which is done by using the mirror. This is most commonly used by dentists, and it is called as Hopkins examination, where you can see the structures. Then coming to direct laryngoscopy, here we use the most commonly used classification is the modified Cormack-Lahane classification, where grade 1 suggests complete view of the glottis, that is the vocal cords are seen. Grade 2A is posterior aspect of the glottis is visible. Grade 2B is only the arytenoid cartilages are available. Grade 3A, the epiglottis is visible and can be lifted to expose the epiglottis. Grade 3B is where epiglottis cannot be lifted even though it is visible. And grade 4 is no laryngeal structures are visible, including the epiglottis. Then coming to video laryngoscopy, here there is a Fremantle score. Here you can see the full view in grade 1, which is an easy intubation, first attempt, and it can be done by a normal direct video laryngoscopy. Partially seen is second, which is modified where more than one attempt will be required and you may need an adjunct like bougie or stylet. And grade 3 is unachievable technique. The video laryngoscopy should be abandoned and you can go ahead with fiber optic intubation. Then coming to Pogo score, that is the percentage of the glottic opening seen. Here it is grade 1 is Pogo score of more than 75%. Grade 2 is between 50 to 75%. Grade 3 is less than 25% is visible, and grade 4 is less than 25%. It is used to predict the likelihood of successful intubation and the potential complications. Then there is a grading for ease of intubation. Grade 1 is no external extrinsic manipulation of the larynx is required. In grade 2 you require measures like external manipulation and birth. Here grade 3 is intubation is possible only when aided by stylet or bougie, and grade 4 is a failed intubation. Then there is a criteria called as RHTMD, that is ratio of patient height to thyromental distance. It is used to assess the ease of laryngoscopy. Ratio of less than 23.5 is easy laryngoscopy. Ratio of more than 23.5 is difficult laryngoscopy. Now, after the single parameters, we club some of these parameters and make a group indices so that we can predict the difficulty in a more better way. So, group indices will be, first is the 3:2:2:1 assessment test, that is Wilson scoring system. Then third one will be Benioff's 11 parameter analysis, Lemon's law, Arnes simplified score models, Saggi and Safevi test, Makbul's 4M score. Coming to 3:3:2:1 assessment. Here we see the mouth opening, which should be more than 3 fingers. If less than 3 fingers, it is a difficult intubation. Hyomental distance should be more than 3 fingers. Less than 3 fingers is difficult. Thyrohyoid distance should be less than 2 fingers, and lower jaw extension, anterior subluxation should be more than 1 finger for it to be easy. Less than 1 finger will be difficult. This is the most easiest method to carry out in the PAC. Then coming to Wilson score. Wilson score consists of, it takes 5 parameters into first is weight, second is cervical spine mobility, third is impaired jaw mobility, 4 is retrognathia, and 5 is prominent incisors. Here we are scoring it between 0 to 10. Here there is 0, 1 and 2. Weight less than 90 kg, 90 to 110 and more than 110 kgs. Cervical spine mobility more than 90 degree, 90 degree or less than 90 degree. Impaired jaw mobility, the inter-incisor gap of more than 5 cm or able to protrude the lower jaw past the upper teeth is grade 0. Inter-incisor gap less than 5 and only able to protrude up to the upper teeth is 2. And 3 is inter-incisor gap is less than 5 centimeters and is unable to protrude the lower jaw to meet the upper teeth. Retrognathia can be normal in 0, 1 moderate and 2 severe. Similarly for prominent incisors, there are no prominent incisors in grade 0. In 1 there is moderation and in 2 there is severe protrusion. Score 0 to 5 suggests easy laryngoscopy, 6 to 7 is moderate difficulty in laryngoscopy and 8 to 10 is severe difficulty in laryngoscopy. Coming to Benioff's 11 parameter analysis, here we take into account the buck teeth, long incisors more than 1.5 centimeters, upper lip bite test grade 2 and 3, mouth opening less than 4.5 centimeters, MPC class 2 and above, narrow or high arched palate, submandibular space, poor compliance, thyromental distance of 6 centimeters, neck movement is restricted, there is a short and thick neck. This combined will give us a good analysis of the overall difficulty in intubation. Then coming to Lemon score. Lemon score consists of, it is a mnemonic, here L is look externally, E is evaluate 3:3:2 ratio, M is for Malam patti, O is for obstruction or obesity and N is for neck mobility. Then coming to Ardey's risk index, it consists of total points. The interpretation is done if the total score is 11, it is associated with high specificity and improved sensitivity in predicting difficult intubation. It consists of history of difficult intubation in the past, pathologies associated with difficult intubation, any clinical symptoms of the airway pathology, thyromental distance of less than 6.5 cm, head and neck movement, modified MPC and mouth opening. Then coming to Sagae and Safa-based test, it consists of 6 parameters. First is weight of the patient, tongue protrusion, mouth opening less than 5 centimeters, upper incisor length more than 1.5 centimeter, MPC more than 1, grade 1 and head extension less than 70 degrees. Here it will suggest a difficult intubation. It is a test to predict prolonged laryngoscopy time and presence of 3 or more factors will suggest prolonged scopy time. Coming to Makbul's 4 M's, here we see for Malam patti scoring, measurement of the mouth opening, thyromental, that is 3:3:2:1 ratio, the movement of the neck and any malformations that can be used, that can be present. The malformations can be at the skull, teeth, any obstruction or pathology. You can remember as Makbul's 4M with stop. Patient score more than 8 suggests difficult intubation. Then some other indices or predictors where we have clubbed them and made a mnemonic. First is bones, which will suggest criteria for difficult mask ventilation. Bones consist of bearded individual, obesity, no teeth, elderly and snorer. Also it can be remembered as moans, that is mask seal difficulty, obesity or obstruction of the upper airway, advanced age, no teeth and snorer. Then third criteria is a hand scale for difficult mask ventilation. Grade 1 is ventilated by a mask. Grade 2 is when you require an airway plus or minus muscle relaxant. Grade 3 is difficult mask ventilation, even it is inadequate with 2 providers. And grade 4 is unable to mask ventilate. These are the short forms, that is bone, lemon, rods and short. Rods is used to assess the difficulty of using supraglottic airway, that is here it consists of restricted mouth opening, obstruction, distorted airway and stiff lung. And short is used for determining the difficulty of front of neck axis when there is a can't ventilate, can't intubate situation. It consists of surgery, hematoma, obese patient, radiation or tumor. Then, I told about rods. Also, predictor of difficult front of neck axis can be remembered as bang. B is for any bleeding tendency in the patient. A is agitated patient. N is any neck scarring or flexion deformity. G is growth of vascular abnormality. Then coming to radiological assessments. Here you will see for atlanto-occipital gap in the, this is done using a X-ray neck cervical region AP and lateral. Atlanto-occipital gap of less than 5 mm. C1 to C2 gap of less than 5 mm. Airway compression or deviation and mandibular length is to depth ratio less than 3.6 suggests difficult intubation. You can also go for CT scan or MRI if available. Coming to advanced assessment tests, here we generally see for flow volume loops, acoustic response measurements and PFTs. Also, what we are going to learn today, that is USG. Then coming to pediatric airway assessment, it will consist of a Cooper's score where you use chin, opening, any previous intubation difficulty. You will see for the uvula, that is, you can do that by Mallampatti scoring. You will see for the range of movement of the neck and any modifiers if needed. Prediction is 5 to 7 is easy, where 16 plus score is inability to do any mask ventilation or intubation. Then coming to planning strategies. Difficult airway can be anticipated or unanticipated. For anticipated difficult airways, we can always be prepared. But we have to be equally prepared for unanticipated intubations. This slide suggests of the difficult airway card. Here you must always have your plan A, B, C, D, E available, and according to that the equipments are present in the drawers. One is for intubation, second is for supraglottic airway devices, 3 is face mask, any other adjuvants that can be done, and grade 4 or the 4th drawer you will have a surgical assist equipments available. Concerns of the unanticipated difficult airway, expert help may not always be available, special equipment may not be available, general anesthesia and long-acting muscle relaxant may have been given. Sugammadex invention has reduced our worry about this. Backup airway management plan may not be thought of prior, which can lead us into conflict. Then coming to difficult airway algorithm given by American Society of Anesthesiologists. First is assess the likelihood and clinical impact of basic management problems. See whether you can ventilate the patient, is there any difficulty in intubation, is the patient cooperative and giving consent, and difficult tracheostomy. Then you see whether you can supplement oxygen throughout the process of difficult airway management. Consider the merits and feasibilities of awake intubation versus intubation after GA, non-invasive technique for initial approach for intubation to invasive technique, and preservation of spontaneous ventilation or ablation of the spontaneous ventilation. For awake intubation, airway has to be properly prepared. If first attempt is successful, very good. If second, consider other options like LMAs. If not, then you will have to go for invasive airway technique. And if the awake intubation is not possible, directly you can, by non-invasive method, you will have to use invasive method. Second is intubation attempt after induction of the general anesthesia. Here, initial intubation attempt is successful or not. If it is unsuccessful, you will call for help, see for and at least attempt face mask ventilation. If the ventilation is adequate, you don't have so much to worry. It is a non-emergency pathway. Here you can use an alternative approach to intubation. If it is successful, good. If it is not successful, then you will have to go for invasive airway or other feasible options that is available. And if the face mask ventilation is not adequate, you can consider for one attempt of intubation. If that is not possible, go for LMA. If that is not possible, go for emergency surgical tract. This is the DAS, that is Difficult Airway Society's intubation guidelines. Plan A is face mask ventilation and tracheal intubation. You do a direct laryngoscopy the oxygenation, here you use the supraglottic airway devices. If you succeed, then you will, it is good. If you do not succeed, you stop and think options whether you can, if supraglottic airways in place, you will think whether to wake up the patient, to intubate the trachea via the supraglottic airway device, or to proceed without intubating, or you will have to plan for FONA. So, plan C is if there is a failed LMA insertion, you will see for final attempt of face mask ventilation. If it is possible, you will wake up the patient and postpone the surgery, make your things available, and then you can repose the patient. And plan D is an emergency where you cannot either ventilate or intubate the patient, where you will have to go for front of neck access via cricothyroidotomy. Then management of unanticipated difficult tracheal airway. First is face mask ventilation and the sequence remains same, but here the help is not available. Many times the equipment is not available, which makes the situation difficult. Here there is a difficult airway societies intubation technique, where here airway techniques where you have to firstly oxygenate the patient. Oxygenation is most important, and for awake tracheal intubation, first you have to properly prepare the airway, keep the fiber optic ready, topicalize and sedate. You can sedate the patient if the patient is agitated, and then go for awake tracheal intubation. If the awake tracheal intubation is impossible or it is unsuccessful, you will call for help. You will give 100% oxygenation, stop sedation, stop and think if the immediate airway management is essential or not. If the awake tracheal intubation is impossible, then you will have to go for FONA, and patient will be high risk for GA. Now coming to failed intubation and failed oxygen in the paralyzed anesthetized patient, first thing, call for help, continue 100% oxygenation, declare cannot intubate, cannot ventilate situation, and plan for emergency front of the neck access. Every anesthesiologist should at least be able to perform ventilation using a cricothyroidotome. If jet ventilation is available, it is very good, but many centers do not have neck jet ventilation. So at least with the NAMBU, we can, using a modified cricothyroidotome, we can at least ventilate the patient. Coming to airway management with induction of anesthesia, review the airway management strategy, pre-oxygenate, induce the airway, induce the anesthesia, see whether the airway placement is successful or not. If it is successful, good. If not, then at least the ventilation has to be adequate. If ventilation is adequate, it is a non-emergency pathway. You will use an alternative device, or you can awaken the patient, or you can go for invasive airway. Not more than 3 or more attempts is to be taken. The time should be less than 10 minutes. Stay and the SpO2, you should be aware of the time as well as the SpO2. If there is no ventilation, you will have to declare the emergency pathway, and here you will try again for face mask ventilation, at least by using 2 provider methods. You can use an adjoint for face mask ventilation. If that is not possible, go for supraglottic airway device. If still it is not possible, you will have to go for FONA, or you can do a rigid bronchoscopy, or you have to go for ECMO. Similar is the ASA difficult airway algorithm for pediatric patients. Pediatric patients are difficult as such also, and we cannot assess them very easily because the kids are not cooperative. So similarly, you will have to be always alert for pediatric patients. In pediatric difficult airway management algorithm, see where with the ventilation by face mask be difficult or not. If yes, it is better to do an awake approach if it is feasible. If it is feasible, awake LMA followed by inhalation induction and intubation can be done. Awake intubation can be done. Awake fiber optic intubation can be done, or you will have to go for awake tracheostomy. If the awake approach is not feasible, the primary approach will be inhalation induction with preservation of your spontaneous ventilation. And you can use adjoints like optimal head position, jaw thrust, chin lift, oral and airway nasal devices, LMAs, tropicalization, anti-cialagogues, and consider awake look prior to induction. If you cannot ventilate by face mask and you do an IV induction, you will be in soup. You will have to look for all the adjuvants present and try to intubate. If not, then we will have to go for front of neck access. But front of neck access in pediatrics is not easy. We do not have pediatric size tracheostomy tubes available. We do not have cricothyroidotomy sets available for pediatric patients. So only the modified cricothyroidotomy can save us that time. This is the guidelines for management of unanticipated tracheal intubation in pediatrics, which I have already said. First, laryngoscopy and tracheal intubation if it is possible, well and good. Otherwise, you will go for supraglottic airway device. If still not possible, at least face masks the patient. Oxygenation is of most importance, not intubation. If you are finding difficulty in intubation at any point of time, at least switch for 100% oxygenation of the patient. And then, if nothing is available, call for additional help and go for front of neck access. Obstetric patients, here the life of mother as well as the fetus is at stake. Pre-induction, you have to plan and prepare the patient. As we know that anyways pregnancy is taken to be a difficult intubation because of the additional pad of fat available. NBM state is always taken as negative, and then we will and also there is difficulty in intubation. Rapid sequence induction has to be considered. Laryngoscopy has to be done by the maximum experienced person. It should not take more than 2 attempts, and if possible, third attempt if required has to be taken by the senior most and most trained faculty. If successful, you can start proceed with the surgery and plan extubation. If it is failed, you declare failed intubation, call for help, maintain oxygenation, see whether you can place supraglottic airway device. If it is, or you can at least ventilate by face mask. If that is possible, good. If not, then you will have to declare cannot intubate, cannot ventilate situation. Here you will fastly have to at least do a cricothyroidotomy and maintain oxygenation. You will have to get the cesarean section done and remove the fetus and then stabilize the mother. Management after failed tracheal intubation. One option is to awaken the patient. Maintain oxygenation, maintain cricoid pressure if not impending ventilation. Either maintain head up position or left lateral position. If rocuronium use, we can reverse with Sugammadex. Assess neuromuscular blockade and manage awareness if paralysis is prolonged. Anticipate laryngospasm and cannot intubate or cannot ventilate oxygenation. After awakening, review urgency of the surgery with the obstetric team. Intrauterine fetal resuscitation as appropriate. For repeated anesthesia, manage with 2 anesthetists available. Anesthetic options like regional anesthesia is preferable, and secure airway before repeating the general anesthesia, that is awake intubation. And when you really have to proceed with the surgery, the patient is in fetal distress or there is any harm to the life of mother, first is maintain anesthesia, maintain ventilation, consider merits of controlled or spontaneous ventilation, paralysis with rocuronium if Sugammadex is available, anticipate laryngospasm and cannot ventilate, cannot intubate situation, minimize the aspiration risk with cricoid pressure. Senior anesthesiologist has to operate as fast as possible, inform the neonatal team about the failed intubation and consider total intravenous anesthesia if possible. The take-home messages, these are the 12 commandments of the airway management. One should never take away anything. Airway ventilation from a patient, that one is not confident one can replace. If you feel there is a difficult airway, if you feel there is difficult intubation, do not remove the tube or the airway unless you are sure you can place it back again. Second, all clinical areas should be equipped with face mask ventilation and direct laryngoscopy for tracheal intubation and their alternatives. Be familiar with and well practice the alternative techniques to face mask ventilation and direct laryngoscopy. In actual difficult airway situations, remain calm. The first priority is always back mask ventilation. Do not intubate the patient. 6 is call for early assistance. If you cannot ventilate, intubate, and if you cannot intubate, ventilate the patient. Keep track of the time. Do not take the things on ego, how I cannot ventilate or how I cannot intubate. Just see whether if you are taking more than 10 minutes, give it to somebody who is more experienced. If nothing is there, there is no harm in giving it. Call for senior assistance. If first intubation fails, think what to do differently the second time to succeed. If you are using a direct laryngoscopy method, you can think of using McCoy blade second time. You can think of video laryngoscopy for second time. If CVCI, you face a situation of cannot intubate, cannot ventilate, you have to open the neck. Practice whenever you can. These are perishable skills. And lastly, in the field of difficult airway management, success is lauded, but failure can be disastrous.